Hi, I'm Dr. Mark Student, and first I'd like to thank ChiroSecure for the opportunity to share today and share our information with you. And today I'm with Dr. Don Capaferri from Atlanta, Georgia. Hey, Don, good afternoon.
Hey, Mark, how are you?
I am great. It seems like we
Good.
meet quite a bit in this venue.
Yeah,
Um, yeah,
in cyberspace.
cyberspace. Yeah, life is good. Thank God for technology. You know, Don, we went to school over 40 years ago, both of us, and we've really seen a lot of changes in research and technology. The good news is chiropractic still works, but thankfully today we know why it works. I mean, the real reason why it works, and we know that there is bone on nerve. It's not just it's not the nerve rooted to the facet level. We know all those things. We know the mechanisms, and together we've shared many platforms teaching that. But one of the things that we're still pushed in a little bit of a box or a corner is how do we know where and when to adjust? How do we know when the patient's well? And it's funny, I had a conversation this morning from a doctor in Pennsylvania on just that conversation. He says, "Oh, I'm with the Blues and they want to know pain scales and they want to know muscle testing and range of motion." And we both know that a good portion of those parameters are from physical therapists working with neurodegenerative diseases or stroke. And they're looking for that to come back, which comes back quick, which comes back very slowly for long care. But chiropractic, I mean, Don, how quick does pain go away? You know, I mean, how quick when you work with the patient?
Well, actually, it goes away too fast. And if you judge whether a person needs care or not by their pain level, you're going to have a pain practice, which pain practice, one of the symptoms of a pain practice is the patient visit average is very low, usually under 20, because you're relieving, you're an aspirin to them and you compete with pain management. And I don't do
And,
that.
and what's the problem with a pain management practice from your perspective after doing this for 40 something years?
Well, I think the bigger problem, the scope of the problem is if you have a pain practice and you pat somebody on the back and say, look, you had 10 visits, your pain number is 1 or 2 or 0, high five, then you're reinforcing the model, the sickness model of healthcare in the United States. In my opinion, one of the worst things that ever happened to healthcare is when pain became a treatable diagnosis. It's not in my office, but it is in the world of medicine. And that led to procedures and treatments only to cover up pain. My wife is a great example. She just had total knee replacement. She's been suffering knee pain for over a decade. And she got a shot called Euflexa, which gave her 8 years of pain relief. Meanwhile, the joint was deteriorating and the femur had crushed the head of the tibia 12 millimeters. And all that was going on when she had no pain. So if you judge a patient's health by their pain, you're doing them a disservice.
You know, Sam Collins from H.J. Ross, which I consider probably one of the most, if not the most knowledgeable in coding in our industry, says that a pain diagnosis is a throwaway diagnosis.
Yeah.
And I couldn't agree with him more. I mean, I agree. So we want to get to the underlying cause of the pain. You know, it's funny, when we went to school, DC stood for Doctor of Cause. Remember that? Oh, you're a doctor of cause. And I'm sure that brings you back to God knows how many years ago. Um, but we always look for the underlying cause. Now we're so busy treating segmentally. The low back hurts, I'm going to treat the low back. The neck hurts, I'm going to treat the neck. And forgetting where to look for the ultimate etiology. So when we look, and I'd like to dissect a little bit of muscle testing and range of motion. So with range of motion, the range of motion is usually limited by two things. Number one, it's limited by muscle spasticity. And number two, it's listed by meniscoid entrapment at the facet level. And if you don't know what that is, you really need to attend one of our primary spine care courses. Actually, the next one is coming up. Well, they're all online at teachdoctors.com, but the next live one is November 2nd and 3rd. But it'll be our 16th one. But we've handled this so many times where through either repetitive micro trauma or a single macro trauma, you know, like a car accident, a slip and fall, a sports injury, sitting on your wallet over and over and over again, or putting a handbag on your shoulder and letting that drag down, um, there's a spacer between the facets. And when it dislodges and it goes out of position, the spacer, you lose the spacer and the facets approximate. And as a result, the nociceptors on the facet, along with the joint capsule, which is now elongated, actually has Pacinian corpuscles, which are your stretch receptors, your Pacinian corpuscles, which are your crimp receptors, your Ruffini corpuscles, which are your stretch receptors, along with Golgi tendon apparatus, along with the nociceptors on the facets, feeds into the dorsal root ganglia, throws over into the deep paraspinal muscles, which through positive ion channels sends information back into the dorsal root ganglia, up the spinal thalamic tract, through the periaqueductal gray area, hits the thalamus, ping-pongs off a myriad of areas and creates disparate pain in different areas. So your body creates homeostasis because you have to be plumb here, 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 and your belly button. So you can't be crooked, even if it's a degree or two. So the body tells the muscles to go in spasm, so you're now plumb. So you've got spasticity all over the place. In addition, there is a direct cause and effect to muscle spasticity with this stuff, and the muscle spasm comes quickly and goes quickly. So when you replace that meniscoid through the adjustment, you're actually fixing the underlying cause of the problem. Now, when we do that, how do we measure? What did you learn in school, Don? Now, forget in the past 5 or 6 or 7 years. What did you learn in school how to analyze the spine on a day-to-day basis?
That's a very interesting question, considering the school I went to. I went to possibly the worst diagnostic education on planet Earth. And the faculty and the administration of that school actually had us practice patient interaction without asking a person how they felt, because we weren't supposed to talk about symptoms. That was the school I went to. Interestingly enough, when you spoke to these same people about their own practice, the only thing they had to point to patient progress was symptoms. Nothing else to point to it, nothing to measure. You can't show a patient what you're feeling with your fingers. You are the only one that can assess that. So I was taught to go by palpation, period. In fact, more specifically, muscle palpation.
Yeah, and I went to what was considered one of the best schools in the country, which is New York Chiropractic College. And guess what? We were taught almost the same thing, palpation. That was it.
I'm pretty sure the administration from my school came from yours, so I'm pretty sure it was pretty close.
You know, it's funny. When we went to school, we didn't have really anything, and the good news is chiropractic worked. We played the piano. We start at the sacrum, and you work your way up to the cervical spine, and did that, and you took whatever the body gave you, right?
Yep.
So we've become a little bit more sophisticated in spinal analytics. Now, there are very sophisticated programs out there, and like CBP, Chiropractic Biophysics. There's Posture Rate's got some interesting stuff. There's other stuff, and it's really good stuff, which is a little bit complicated, but it's really good to help you understand what's going on with the human body. But Don, you're involved in a program with me that really has been a game changer in creating a simplistic level of creating an accurate spinal analytic scenario. And it's called Simverta. It's an X-ray digitizing program. And there's a lot of programs out there in X-ray digitizing that only look at AOMSI, alteration, motion, segment integrity, which this does also, but from my perspective, it's really not the most beneficial thing. But it's really changed how we do things. Now, it does involve X-ray. And Don, how dangerous is X-ray?
Not dangerous at all.
And do you remember the numbers? How many X-rays you could take in each spinal level?
I think it's 5,000 lumbar X-rays on a single visit. Next, cervical X-rays. Okay.
And that's my fault because I didn't have my glasses on. I didn't see the decimal point. It's 500. I swear, that's the truth. I could. I took my glasses off like this to wipe my eyes when I typed, and I put my glasses. I didn't look, but it doesn't matter. It doesn't change the outcome. It's
No,
500 cervical X-rays and
500. Okay.
67 thoracic and lumbar, 5,500. When's the last time you, me, or any chiropractor in industry in one setting took a minimum of 500 X-rays on the cervical spine?
Never. I mean,
Never.
I've been in practice 42 years, and I've never taken that many X-rays on any individual patient ever. So
Yeah. So, and it's not taught, it's not inherent within our training. And X-rays are also not cumulative. What you do today, tomorrow, the next ray, it doesn't add up. So
right.
we know. And also, as far as intra and inter-rater reliability, there's close to 100% consensus with X-ray. Where with motion and static palpation, it's poor and failed, and 3% and 6%. So X-ray is exceedingly liable. So we're using this tool. And by the way, the tool, just to be very clear, the tool does not tell you what to do. It doesn't tell you what to do. It's a measuring instrument, but it gives you a guideline for you, the doctor, to make a clinical decision on what to do. Would you say that's about the most accurate statement?
Yeah, it's like a lab test to an internist. The lab test doesn't tell them what to do. It tells them what the person's state of their blood chemistry is today. That's all. Our machine, our tool, tells us what the biomechanical state of that person's spine is today. Once you intervene, now that biomechanical thing can change.
All right. So tell me how in your practice you use this tool with your patients on an everyday basis. And why don't you explain what the tool is actually?
Okay, it's called Symverta, Symverta. If you are curious, go to symverta.com and check us out. I call it a biomechanical software platform because it does do the AOMSI. If you don't know what that is, that's alteration of motor segment integrity. It kind of is in the personal injury space. So it does that and does that very well. In fact, we're the only ones report on translation pathology for C1 and C2. We're the only ones that do that.
And Don, 1 second, just so that this is not an advertisement for Symverta, that's not the purpose of today. You could take a plain film and do it yourself. All this tool does is it measures for you. You could do this yourself. So explain what this does so they can do it themselves if they choose.
The one part of Symverta that's difficult to do without a software program, I don't necessarily think it's just this software, is the process works like this. Let's just take cervical spine. I take 4 cervical spine x-rays, A to P open mouth, lateral neutral, flexion extension, and I plot points on the bodies of the vertebrae, starting at the bottom, going to the top. And Symverta will then measure the motion of each segment and its relation to the segment above and below, and it reports on that. More importantly, in my opinion, than telling me where and how, it does tell you how to adjust if you want to follow. Obligated to follow that.
Explain what you mean by how.
Line of drive, superior to inferior, inferior to superior, or rotational pathology. It'll tell you to adjust on the left side of T7 and on the right side of T3. It also gives you what a primary lesion looks like compared to compensations. That might take a little bit of training. That's probably the most complicated part of Symverta. So every person, regardless of whether they're 5 years old or 100 years old, in my office gets a biomechanical study. Then that is the baseline. I treat based on the information. I adjust based on the information that I get from that. And in 30 days or 12 visits, we take another Symverta study to see what I've accomplished. And the new x-ray study does not at all depend on how they feel. 99% of the time, their symptoms are or greatly diminished. But whether they continue at the same schedule, at a lesser schedule, or are discharged depends upon the biomechanical study. And patients get very excited about seeing the updates. They get very excited about that.
And because you're x-raying every 30 days, now some people do 30 days, 60 days, some people choose to do
Yeah.
90 days of clinical decision. We don't worry about negative sequela from x-ray because
No.
there isn't any. There isn't any. So, and
No.
on, go ahead. Wait, you're frozen. Can't hear you. So, what we look for when we do this is we're looking actually for patterns. And you're looking for patterns in rotation, patterns for inferior to superior. We're looking for all of these different things, which will help you make a clinical decision of when to adjust your patient and where to adjust your patient so you can make that decision on how to move forward. And that's really important because, you know, when you're doing, when you're looking at normal muscle tests and range of motion, you see the problem isn't too little range of motion. The problem is too much range of motion when you have excessive motion. Because what occurs is when the ligament overstretches, the ligament is made up of collagen and elastin. So when the ligament overstretches, it tears actually, because there's only a 0.78 to a 1 millimeter, 0.78 to a millimeter is not a lot of give in that ligament. It's got contractile and expansive ability. But when it goes beyond that threshold of a millimeter, it tears. And when it tears, and again, we're sorry about Dr. Capoferri. He lost his bandwidth and he's gone. So you'll have to suffer with me for the next 10 minutes or so. So when the ligament overstretches and tears, it wound repairs, it heals. It doesn't heal, actually, it wound repairs. So collagen and elastin are in there. And how the body wound repairs, it can only replace collagen. Because what occurs is those fibroblasts from a neonate, from the newborn, those fibroblasts, when they're growing, stop making new ligaments. So when the fibroblasts go and make new ligaments, the body's growing and it's growing. Then when you hit puberty, those fibroblasts stop producing new ligaments. Now it stays dormant. So when you have a tear, which in a ligament, I mean, literally a tear, okay? And most we deal with is partial tears, not full thickness tears, partial tears. So when you have a tear, it now, you back on? So when you have a tear.
I think so.
Okay, hang on, so let me just finish this off. So when you have a tear, the ligament starts to wound repair, and now you only have collagen. It's no longer replacing elastin. So over a period of time, that wound repair creates a permanent problem. And Don, I was leading up to, I just talked about the collagen, elastin, wound repair. So when you have that, you're now creating a negative pattern, and it can never be fixed. So that's when you know your patient has gone from corrective care to maintenance care to maintaining it. You can't correct it. Let me rephrase that. I don't want to use the word maintenance. I want to use the word management. You're managing your case. Just like they manage diabetes and high blood pressure. Okay, you can manage it, but once you have it, you got it. So once you have this wound repair and it's been there, so Don, you're going to look at a pattern, say, cervical, thoracic, lumbar, and it's based upon how much rotation at the apex of the curve that's aberrant, okay? That's or pathologically rotated. So if you see that pattern and it's not normalizing in your Simverta report or your biomechanical study, at what point in time do you say that's chronic and I have to manage it versus it got better and it's biomechanically stable?
Any positive findings, whether it be in rotation, whether it be in AOMSI, translation, or angular deviation, all of those pathologies are permanent.
Well, the point is, though, if you get them early on, can't you fix that?
No. The tissue damage is permanent. Ligaments do not heal. They don't heal in 1-year-olds. They don't heal in 100-year-olds. They scar. So that's the function of that tissue is permanently compromised. When I get a Simverta study, I adjust based on the rotation report. But when we do a follow-up, we always go back and revisit the AOMSI. And what we'll find is the extremes of hypermobility in AOMSI tend to mitigate and come into line with the ones that aren't hypermobile. And essentially what you've done is rebalance that spine. Once that happens, a person goes on management care. I'm going to use that, by the way. I like that instead of maintenance. Definitely.
But I think we're going to create that buzzword in the industry. We're going to talk it biomechanical pathology management.
Management. Perfect.
I like that because we're managing the spine. And why is that important versus maintenance care? One, carriers don't consider maintenance care just from a financial perspective. But two, we're now in line with what's usual and customary in healthcare. I've heard this, and you've heard this. Don, are you a medipractor? Are you practicing medicine as a chiropractor? Have you ever heard of that?
I have not heard that because I don't usually socialize with other chiropractors except you. So
it's sad. No, but I've been called that before. I've been called everything. You name it, I've been called it. The medics call me names, the chiros call me names. But here's the thing. I believe that you have to use the words chiropractic spinal adjustment. You have to. Non-negotiable. We don't manipulate. Non-negotiable. But when we talk about subluxation, and both of us come from a very strong subluxation background. Both of us.
Right.
Okay. And I was a high volume practitioner, families, kids, you name it. But when I would talk to the surgeons and the primary cares that I work with, they look at me like I have 5 heads. What's wrong with you? We don't use subluxation. You mean the bone sitting on the shoulder? And then they would smile and they shake my hand. They call me an idiot in the back of their mind, and they never work with me again. When I changed my language and I said we treat biomechanical pathology, which is subluxation, it's synonymous, all of a sudden the light bulb went off in their head. And they said, you know what? He said, we understand that and we get it. But we don't know who treats that, but you do. And all of a sudden referrals skyrocketed. So would I rather hold on to my lexicon of subluxation? And I'm not saying don't teach it, don't understand it, don't know it. You've got to. It's part of our history. It's what we do. It's it's what we treat. And I get it. But in our communication, if I held on to that, and truthfully, I'm a numbers guy. I'm a big numbers guy. And I could tell you that I'm just looking at statistics, that I started taking statistics in 2012. For the first 2012 to about 2020, we got about 900,000 referrals with doing things like Simverta, doing things like working with attorneys and patients. It was great. Once I changed that language, in under 4 years, we picked up over 1 million referrals. We're at 1,935,282 referrals as of today. So that number skyrocketed in part, not in whole, but in part, because we're dealing in language that's consistent with mainstream. So would I rather hold on to something and see a quarter of the patients, or do the exact same thing with my unique chiropractic spinal adjustment and talk about something people can relate to, and now all of a sudden in our lifetime see the masses and those numbers explode? I don't know where your feeling is.
Wow, that would be great. Here's the problem. When you say subluxation to a medical doctor, they hear dislocation. And the thought that you would adjust that. I mean, picture, Mark, how nauseous you would be if somebody showed you a Simverta study and C1 was moving 5 millimeters and this person was cracking that person's neck. You'd want to throw up, right? That's how they are when we talk about subluxation. It's if they would take me and plant me in a country where I don't speak the language and I don't speak any other language but English, and some people think I have a hard time with that. So you have a good opportunity, if you don't know any words in this language, of offending somebody or being misunderstood. And that's what it was like for us when we were trying to talk to medical doctors saying we treat subluxation.
So you experienced the same thing?
Oh, absolutely.
Now, since you changed your language and you're credentialed, highly credentialed, I'm not going to get into, well, you're a fellow in primary spine care and biomechanics and spinal trauma. So you've really advanced your credentials through medical academia. And if someone wants to learn more than welcome to call me. But through changing your language and using this tool, do medical doctors or surgeons reach out to you?
Oh yeah, my best referrer is an extremity orthopedic surgeon. That's counting my patients and counting attorneys and counting everybody. My best referrer is an orthopedic surgeon.
Why?
Well, one, I worked with him in one of my fellowships, and it's really a great marriage. People come to an extremity orthopedic surgeon with hip pain. He examines them and says, "Not your hip, it's your back. Go see Don." And people go to him with shoulder pain. He says, "Not your shoulder, it's your neck. Go see Don." Or if it's their shoulder, he'll treat them, right? But if he finds it's originating from the spine, he sends them to me.
Yeah. So, it's funny. Dallas in Louisiana, who's also a fellow in primary spine care, was working with a neurosurgeon. And I spoke to the neurosurgeon many, many times. We've become pretty close. And he said, working with this digitizing tool, this inverted tool, is a game changer for him. Because now all of his spinal cases, most of them, he starts with Dallas in Louisiana, in Monroe, Louisiana. I think it's East Monroe somewhere. I don't know. Somewhere in Louisiana, I don't really care about. But he said he sends them all there first, because why should he waste his time, evaluating these people if they're going to be non-surgical, which is like 99% of them. They all go there first.
Mark, what's the parent company of the Blues? What's it called?
Blue Cross Blue
You
Shield?
don't know? Huh?
Not
No,
Verizon.
there's a parent company over there. Anyway, I got an email from that company because I have a policy with the Blues, and it delineates if a surgeon is a spine surgeon, what criteria will force him to do fusion versus an artificial disc. And Simvert is perfect for that because it states right in there, if there's more than 3.5 millimeters of translation, you have to fuse. You can't use an artificial disc. If there's more than 11 degrees of angular deviation, you have to fuse. You can't use an artificial disc. And Simverta does all that for the surgeons that you know. Or maybe you're on here and you're a surgeon and you want to get that tool. That's how you do it.
And you work with the doctor who'll do it. I mean, it's just no, that's one of the things we do. But it really takes all the guesswork out. There is no longer, it's not hunt and peck anymore. There's no more guesswork. And you know who really likes this the best? The malpractice companies. Because it really gives, and insurance companies actually, insurance companies don't know what to do with us. Because if there's no muscle testing and range of motion, they want to deny it. You can't refute a demonstrable digitizing, showing biomechanical pathology, which is evidence-based of how much, I talked about it before. 0.78 is the average of ligament pathology. That's how much it can expand before it tears, with a 0.22 standard of deviation. So it goes down to 5, 6, or up to 1. So we consider a 1 millimeter the baseline. We err on the more side. Yeah, Don?
No, I was just seeing if my camera was still working.
Oh. All right. So we err on the higher side at 1 millimeter of weight. And by the way, we did a huge dive into the literature. I mean, huge. It took almost, I would say it was close to a 2-year study working with doctors around the country, looking in the research to come up with this. So there's a lot of issues going on that are, that go behind this, but it's all evidence-based. And the statistical, what's the word when you test it to make sure it's correct? We use the line that's called the line to and from, which you put the number in.
Reference line.
Thank you. It's a reference line to, I can't think of the word.
You're telling Simverta what the millimeter length is.
You are calibrating. That's the word. We calibrate every single test to the eighth decimal based upon the PACS device digital image of what we're doing. It's to the eighth decimal. So we're pretty excited.
Yeah, that's pretty accurate.
Calibrated to the eighth decimal. Even though we only list 2, it's calibrated to the eighth based upon what the DICOM viewer shares with us. So we're very, very, very excited about that and that information. So it's all good. So Don, listen, This was an interesting conversation. You know, we talked about X-ray. We talked about communicating with people in the medical community so they understand what we're doing to help build practices. We've talked about chiropractic in its infancy and what it's used. We've talked about muscle testing and range of motion and static and motion palpation, having poor inter and intra-rater reliability. We've talked about the use of digitizing, showing an extremely reliable level of digitizing. Um, and everything, you know, it's all there. It's all there for you to take. So listen, if you have any questions, you're more than welcome to call me, call Don. I'm all over the place. You can go to Symverta, SYMVERTA.com, or any of the other digitizing programs out there. We've named a few during this presentation. You know, it's not only about one tool. There's a lot of tools out there. So with that being said, Dr. Capoferri, thank you so much for your time. Cairo Secure, again, thank you so much for the platform to share, and we'll catch you next time.
Okay. Thanks, Mark.